Good morning, everybody. I come with another case. This is a 12-year-old boy who complained of seizures, vomiting, blurring of vision, and headache for 20 days. His MRI revealed a well demarcated, vividly inhomogeneously enhancing mass measuring 31 into 28 into 34 millimeters, involving the left thalamus, the left cerebral peduncle, medial portion of the right cerebral peduncle, and posteromedial portion of the right thalamus. The mass was T1 isointense and T2 and flare hyperintense. There was no evidence of diffusion restriction. Peritumoral edema was present. Spectroscopy revealed significant choline peak and no fat necrosis or hemorrhage was noted. Navigation guided biopsy was done from the thalamic region. We received a chunk measuring 0.8 into 0.6 into 0.2 centimeters. We did histopathology, which revealed a tumor composed of large round cells arranged in, you can see the cells are arranged in diffuse sheets and lobules. The nuclei of the cells are large, round to vesicular with prominent central nucleoli. The cytoplasm is moderate to ample in amount and it is clear to pale eosinophilic. Now the cytoplasm gets this clear appearance. This is because of the glycogen content which is Pas positive. Now these neoplastic cells, you can see these are separated by delicate fibrovascular septae which show infiltration by small lymphocytes. The other additional features which may be present in such tumors, now all these features, they suggest it is a germinoma. The other features present in germinoma could be florid lymphoplasmacytic or histiocytic aggregates which obscure the tumor cells. The mitotic activity may be variable. Granulomatous reaction may be present which may mimic tuberculosis or sarcoidosis, and a small subset of germinomas may show presence of syncytiotrophoblastic giant cells which secrete beta HCG. Now sometimes this tumor may be admixed with embryonal carcinoma, yolk sac tumor or choriocarcinoma component as well. We performed immunohistochemistry which revealed plaque positivity, SARS-4 positive and c-KIT was expressed. So all these markers, they confirm the diagnosis of a germinoma. Now this tumor was CD30 negative which ruled out embryonal carcinoma. We did INI1 which was retained in the tumor cells. So the possibility of atypical teratoid rhabdoid tumor was ruled out. Synaptophysin negative ruled out medulloblastoma. LCA negative ruled out lymphoma. And we did the glial markers, that is GFAP and OLIC2, which ruled out the glial tumor. So we gave a diagnosis of germinoma of the left thalamic region. Now coming to discussion, germ cell tumors are two types, germinoma and non-germinomatous germ cell tumors, which could be mature or immature teratoma, embryonal cell carcinoma, yolk sac tumor, choriocarcinomas. Now these components may be one or two or more components may be present and it may be a mixed tumor. Now recent molecular study analysis reveal there is activation of MAP kinase and or ACT or mTOR mutation found in these tumors. Now, the germinoma is the most common intracranial neoplasm. They are mainly centrally located in the midline. Pineal region is most common, followed by the suprasellar component. Now, these tumors may be bifocal or multifocal. In the East Asian children, the basal ganglion is the most common site. Even thalamus or periventricular location of these tumors is common. Now the age group affected is children and young adults, and males are more commonly affected. A germline variation in JMJ-D1C is noted. It may be associated with syndromes such as Klinefelter and Down syndrome. Now the germinomas are usually solid tan white soft friable tumors, and usually they do not exhibit hemorrhage, or we need to run a panel of antibodies to confirm the component of the germ cell tumors. Now the germinoma will exhibit positivity for OCT4 and SAL4, but the c-KIT is most specific marker which confirms the diagnosis of germinoma. You can see SAL4 is positive in all the germ cell tumors. Now the embryonal carcinoma is confirmed by positivity for CD30. The yolk sac tumor, it shows positivity is confirmed by alpha fetoprotein, and for the choriocarcinoma, beta HCG is the most important marker. Now coming to treatment and prognosis, they have relatively good prognosis. 5 to 10 year survival is seen in 75 to 95% of patients versus 25 to 40% of non-germinomatous cell tumors. Now germinoma is very sensitive to radiotherapy and chemotherapy. The non-germinomatous germ cell tumors are less radiosensitive. Metastasis could be due to surgical displacement of the tumor, and spinal cord metastasis occur in 10 to 15% of cases. Thank you very much.